some additional testing. So when we look at diagnostic procedures, when we look at ways that we're going to evaluate, we've got a number of different things that we want to do. And part of the things that we do is going to be in a patient interview. So we have this Epworth sleepiness scale, we have a fatigue severity scale, and we have a visual analog fatigue scale. So is this something that is truly caused from a sleep disorder, or is this something that is more to fatigue, and you may have anemia or your electrolytes are out of balance leading to your fatigue? So a lot of times these sleepiness or fatigue scales are recognizing and they're looking at how sleepy are you. So I'm not going to delve into the Epworth sleepiness scale says you ask these particular questions and they have a scale of this. There's basically in your patient interview and your assessment, you have a number of different assessment tools that you can delve into, and just know that these are available to us, and we utilize these in our assessment. We also want to make sure that we look at the Mallampati score. Well, we just talked about the Mallampati score with bronchoscopy. We talked about the Mallampati score with intubations. So when we look at the Mallampati score, what this does is this looks for any abnormalities in the posterior pharynx, maybe a large uvula, enlarged tonsils, a long soft palate, redundant lateral pharyngeal walls, macroglossia. What do we say macroglossia was? And then a severe overbite. All of these are part of what we're looking for and what we're assessing for our patients when we have them do this. When we look at it, there's a class 0 to a class 4, or the book that I used as a reference has classes 1 to 4, but a class 0 is any part of the epiglottis is visible. When we look at this class 1, we have the soft palate, the uvula are all easily seen. So we get a good visual of what's going on in that posterior pharynx. Then we get a class 2, and the soft palate and the uvula are visible. And then we look at the class 3. When we look at class 3, only the soft palate and the base of the uvula is visible. And then in our class 4, only the hard palate is visible. So all of these things give us insight as to how difficult of an intubation that may be. It gives us insight as to, what size or what device we can use when it comes to bronchoscopy. And it tells us how likely that patient would be to have an obstructive sleep disorder. So lots of functions when it comes to the Mallampati. When we look at other criteria or other diagnostics that we're looking at, we've got a PFT, we've got ABGs, COWACs, or carboxyhemoglobin, we've got chest x-rays, EKGs, echoes, and other blood work. So when we look at this, if we have this for a prolonged period of time, we could have patients that have reduced volumes and reduced capacity. When we talk more about PFTs, we'll get into more of the specifics with this, but just know that you're going to have changes with your PFTs, especially if these patients go with obstructive sleep apnea and it's untreated. ABGs, typically you may get this movement into a COPD blood gas where they live with chronic hypoxemia and chronic hypercarbia. So that we would see. When we look at the hematology, I'm going to jump ahead just a little bit. When we look at the hematology, we're looking for polycythemia, and we're looking for a reduced thyroid function or even bicarb retention. That bicarb goes up secondary to the hypercarbia. So it's a response. With that, you get a change in your chloride as well. So your chloride will be impacted from this as well. So just sticking with the hematology and the blood work, the COHB, this is the corrected oximetry oxygen saturation. So what can happen is you get carbon monoxide or carboxyhemoglobin that has taken the place of where oxygen can bind to that hemoglobin. And let's say that a patient's saturations are 90%. Well, if their COHB, is set at 7%, right? Well, that patient's not really saturating 90%. You have to take away the percentage that the COHB takes away from the total saturation of that hemoglobin. So remember, oxygen binds to the hemoglobin, but if the hemoglobin already has spots occupied, oxygen can't bind to it. And when we look at the COHB, the carboxyhemoglobin, what we're looking at is places where oxygen cannot bind to the hemoglobin. And so if we have an oxygen saturation of 90%, a COHB of 7%, that patient actually only is saturating 83%. And the way we get that is you take the oxygen saturations, your SpO2, and you subtract your COHB of 7% to end up with 83%. So just another thing to kind of look at when it comes to taking care of patients that may have obstructive sleep apnea. You want to get a chest x-ray, you want to get an echo. These things are going to talk to us and show us and help us evaluate the presence of pulmonary hypertension. Remember, these patients aren't oxygenating. Their PaO2 is low. Their PaCO2 is elevated, which will drop their pH. All three of those things influence the pulmonary vascular resistance. If my PVR goes up, well, that increases the afterload of the right ventricle, making it harder for that right ventricle to get any blood to the lungs. So those patients end up with pulmonary hypertension. So with the echo, we can look at the function of each of the chambers. With a chest x-ray, we might see cardiomegaly, especially on that right ventricle. These patients may end up with cardiac arrhythmias, so we could see those populate in the EKG. But the mainstay when it comes to diagnostics for sleep disorders is going to be a polysomnography or a sleep study. And we can differentiate between home studies and we can differentiate between in-lab studies. But when we look at what the gold standard is, it is a full night attended in a laboratory, in a polysomnography laboratory. That is the gold standard. You do have some like home study kits. You have some organizations that are out there that are helping get more information to the patients and allowing them to sleep in their own home, to do this in the comfort of their own bed. Then we have what's called a split night. A split night is a patient that most likely has moderate to severe obstructive sleep apnea comes in, and we can kind of recognize it right away. We're able to evaluate those events that happen. Remember, we only need 5 events in an hour for them to get that diagnosis of OSA. So we look at the patient, are they having those 5 events? If they are, we can go ahead and make the diagnosis. We're not making the diagnosis, but we can pass the information along to get the diagnosis of obstructive sleep apnea. And we can go ahead and split the night into 2 to get the patient titrated for the right device, whether it's BiPAP, CPAP, or an adjustable pressure like in AVAPs, to help the patient get the right treatment for the diagnosis that they have. So lots of different things when it comes to taking care of these diagnoses. These sleepiness and fatigue scales are going to be more in your patient interview and your patient assessment. Mallampati, this is part of our assessment. Lots of changes when it comes to the hemodynamics. But the gold standard is going to be a full night attended in a sleep lab. Then you have the home studies and you have a split night. So a couple of different terms when it comes to taking care of the diagnostics. So when we look at the sleep study itself, this is a specialized sleep test monitoring parameters during the sleep. So we're monitoring the EEG. So we're looking at brain activity while the patient is asleep. It could happen to babies, but a lot of times we see this with adults. we're getting esophageal monitoring, we're getting ocular monitoring, we're getting an EKG, we're getting nasal and oral airflow. And then we have a belt that goes across the chest and across the abdomen to identify and detect any abdominal or thoracic efforts. So, talked about it in the last slide, but the full night in a sleep lab is the gold standard. Anytime that you see anything that has gold standard in it, highlight it, underline it, put a star by it, make a note card about anything that you see with gold standards. When we talk about the full night versus the split night, full night would be utilizing the entire night to chronicle and document all of the events that patient has. A split night would be you're identifying the diagnosis and starting to get the therapy or the treatment that patient needs. Split nights are starting to become a little bit more common. It's definitely more cost effective for the patient, and it's easier for the clinicians because they are only scheduling one test instead of multiple. So some pros and cons when it comes to the split nights versus the full night study. OSA is established as the in the first portion of the night, the titration study of the BiPAP or the CPAP. We kind of covered that there in the split night. The only time that this can actually be done, though, is if you can identify and diagnose and you can complete the therapeutic. So I don't want to evaluate my patient for 6 hours for identifying the diagnostics of, hey, they do have sleep apnea or obstructive sleep apnea. Let me be specific. I don't want to spend 6 hours doing that out of an 8-hour night and then wake that patient up to get them accustomed to any of the headgear or any of the interfaces that they may have to wear, to then try to titrate it to a point that the device is fully functioning and the patient's getting a true full night's rest. So when it comes to the split nights, right, we have to be able to complete both if we are going to try to get a split sleep study or a split night, if you will. So a couple advantages of in-home studies: you get to sleep in your own bed. You don't have to go to some foreign area, to a lab where somebody's going to be watching you sleep. You get to do this from the comfort of your own home. You get a brown box and container of all of the electrodes and all of the monitoring equipment for you to put on yourself so that you can try to get used to that before you go to bed. There are some facilities that you put on the home gear at the facility and then you wear that gear going home to then get ready for bed. So a couple of different things. When we talk about in-home sleep studies, we're going to limit this to moderate to severe OSA though. We're not going to use this for mild nearly at all. So it's definitely used for moderate and severe. Some disadvantages of the in-home study: if you notice where we are currently with our technology, there are more disadvantages than there are advantages. As technology progresses, could this change? Absolutely. This could flip into where we have more advantages of doing in-home studies than there are disadvantages. But so when we look at these disadvantages, what we're talking about is there's an absence of trained technicians that are there to troubleshoot any of the equipment if something were to be misplaced or disconnected. There's nobody there to troubleshoot it. Inability to intervene medically for anybody that's unstable. There have been patients that have actually coded during their sleep study. They were just so sick that they ended up coding. And if you're doing a sleep study at home, then you don't have the medical personnel to operate and take care of and function in that capacity either. You could end up with lost data inadvertently, or if you don't put the electrodes on appropriately, it could end up with distortion or erroneous values. There could be interpretation errors from a limited data source. You get the inability to perform subsequent or multiple sleep latency tests according to the standard protocol. You get a varied sensors in their technology, and there's no published standards or scoring for home studies. When we do record and when we do have patients that have in-home studies, we're looking at the nasal airflow, we're looking at pulse rate, chest or abdominal efforts, and the pulse ox. So it's not giving us as much information either when it comes to what we're recognizing, what we're evaluating, and the information that we can provide to our providers so that they can get the right diagnosis so that we can get them on the right treatment. So still some work to do with in-home studies, but that doesn't mean that we won't see advances by leaps and bounds when it comes to these home studies. But when we look at these calculations, it's giving us a little bit different insight as to what's going on with our patients. So we have two different calculations that we can use in lab versus in home. So here we see that the AHI is associated with in lab and the RDI is associated with the home study. And when we look at the AHI, we're looking at the apnea to hypopnea index. And then over here, we're just simply looking at the respiratory disturbance index. Now, the difference is you're still looking at events or epochs. Epoch is another term that we use in the sleep world. But we look at these events here and we compare it to the total sleep time, and you have the same kind of number of events, but we're looking at the total recording hours, or total recording time. And so when we look at this, we have an AHI or an RDI, and let's say that we have 100 apneas and hypopneas over 8 hours. So if I were to look at my 100 hours in apneas over 8 hours, I divide 100 by 80, I ended up with about 12.5 on my AHI score. So if I have a 12.5, it's telling me that this patient has a significant number of events throughout the night. The number that I want on both of these, on the AHI and the RDI, I want both of these to equal less than 5.